I am Dr. Jared Gardner, and I'm here today with one of my residents, Dr. Terrance Lynn, and we're going to go over some soft tissue pathology unknown cases. I'm going to grill Terrance on these, and I'll save his good answers, and if he gets them wrong, I'll delete them out so he'll look like a total all-star because he actually is. So, all right, so anyway, let's, whoops. All right, let's do this. Okay, so case number 1. What do you think about this mass right here? Well, first of all, what's the history? The history is a 15-year-old female with an anterior thigh mass. So what did you think about this?
So one of the things that I noticed was the thick fibrous septi providing this mass. And then within the mass, you see almost this alveolar, what I would say an alveolar pattern.
Sure.
And then you see the pleomorphism of the cells. And they're kind of arranged in, as I said before, the alveolar part pattern. And divided by the septi, eosinophilic cytoplasm.
Yeah.
Nuclei.
Let's see if we can get in to see the nuclei here. There we go.
Have some prominent nucleoli.
Yes, they do.
And slight pleomorphism of the nuclei themselves. Some of them can be peripherally located, it looks.
Yeah, a little bit. They get kind of that almost rhabdoid or plasmacytoid kind of look with pink cytoplasm. Right. Sure. All right. So, what did you? What's your diagnosis or your differential here?
So I believe this is an alveolar soft part sarcoma.
Very good. That's exactly what it is. Excellent work. And let's see. What were the questions we asked? Okay. Do you know what the molecular abnormality is?
Translocation of X17.
Yeah, exactly. And involving the TFE3 gene. Okay. So TFE3 is going to be positive in the nuclei of these cells usually. And there are a variety of other things, including some of the, I think the XP11 renal cell carcinomas, some solid pseudopapillary tumors of the pancreas, if I recall, and a subset of epithelial hemangioendotheliomas. And I think there's one or two other things that I'm blanking on, and surely eventually there'll be more. But TFE3 is not totally specific, but it's a pretty good marker here. Although this is a really distinct looking neoplasm, right? I mean, it's very, not much else looks quite like that. I think the main differential in my book would be like a metastatic renal cell carcinoma, because there are some renal cell carcinomas that can look kind of like this, and I'm not a GU pathologist, but to my eye at least. So I think that's a good thing to keep in mind. And how did you know it wasn't alveolar rhabdomyosarcoma? Because a lot of times people get those two confused, but they actually look quite different.
I didn't see the wreath cells.
Oh, that's a good point. Yeah, you have multinucleation wreath cells, good, in alveolar rhabdo. And I think the way I think these tumors, alveolar soft part sarcoma, is a big pink cells, right? Pink or clear. And alveolar rhabdo is a round blue cell tumor, right? It's like cellular round blue cells. It does make kind of that similar architecture, but that's really where the similarities kind of end. And, see the intervening vessels can be kind of prominent, just like you'd have in a renal cell. So you could certainly do, keratin, PAX8, something like that. In this case, it's a 15-year-old, right? So that's pretty unlikely to be a renal cell. And one other thing I really like to point out about this tumor, and this is a really particularly good example of it, and this was taught to me by my mentor, Mark Edgar, who I worked with when I was in fellowship. Mark Edgar and Sharon Weiss were both my mentors and taught me a lot of great stuff. But one thing I really liked, Mark has a lot of these little visual clues that are kind of funny and cool, and they really resonate with me. Like he's like, oh, these cells look kind of like an apple that someone took a bite out of. See how it's got little notches in the nuclei? See all these little cells, or kind of like a Pac-Man or something, right? They have these little divots or notches or kind of crinkled edges to the nuclei, and that's not always there, but it's often present in alveolar soft part sarcoma. So I find that a really useful little clue. So kind of a fun visual analogy, but one that's actually diagnostically useful. I think the big nucleoli, like you said, it's a good feature. They often have large nuclei with big nucleoli. And, these are translocation sarcomas, and the general rule is that translocation sarcomas don't usually have pleomorphism, okay? They usually have uniform monotonous nuclei because all the cells have the same abnormality. But for whatever reason, and I'm not sure why, alveolar soft part sarcoma seems to break that rule. It tends to have some scattered pleomorphism. I would say most of the cases I've seen did. So that's kind of different than a lot of the other translocation sarcomas. The other thing I'll point out while we're here, because this case shows it pretty nicely, let me find the area. Well, maybe here will work. If you just had a biopsy of this, you might really struggle, right? Because that doesn't look alveolar at all. It looks like instead little small nests or kind of individual cells or small nests or maybe almost trabeculae of tumor cells with clear to eosinophilic cytoplasm. And, again, you could confuse it with renal cell carcinoma. I also think even though cytologically it looks different, that kind of reminds me of the Zellball in appearance of a paraganglioma a little bit. So you can have areas like this in alveolar soft part sarcoma, like there. And sometimes they can be quite prominent where you don't really have any of that alveolar pattern. And those can really give you a hard time. So it's good to keep this in your differential. I think when I think of paraganglioma, I try to make sure I think, oh, could it be, especially if I'm in soft tissue, like in a non-usual site where paragangliomas wouldn't normally occur. I try to always think, keep alveolar soft part and paraganglioma in mind. Although, again, the nuclear features are kind of different between those, and immunostains would easily sort it out. But I think this is not on people's radar that alveolar soft part sarcoma looks like this, because everyone thinks of only the alveolar pattern for it. So these are really, really rare. I've only seen, I think I've only diagnosed myself one in practice in 8 years, and I've seen a small handful of other ones, but I mean, I've only rarely encountered them in routine practice, even when I was doing consult cases in my former position. So alveolar soft part sarcoma, they tend to, here's more of that Zellball kind of look. See that? Kind of solid nests that haven't fallen apart yet, right? Because that's what happens. The alveolar look is that you get these kind of nests and then they fall apart in the middle, and the peripheral cells kind of stick to the basement membrane around the edge of the nest, or the collagen, around the edge of the nest. And then in the middle, they kind of are free floating a little bit. And so, but yeah, that's kind of a unique pattern there. So, but yes, they do, a lot of these will metastasize, unfortunately. Although they can be kind of slow and take a long time to do that, they do tend to spread. They can spread to weird sites, like in addition to the lungs, they can go to the brain and other unusual sites, which is a very strange and unusual tumor, unfortunately. Can be aggressive, though. All right, so that was case one. Now, the next one, let's see, is also a 15-year-old female with a deep soft tissue mass of the leg. And as you can tell, I make up all these histories pretty much, so. All right, so what did you think the diagnosis was for this one?
So I believe this would be the alveolar rhabdomyosarcoma.
Good. Yeah. That's what it looks like to me. I probably should check my answer sheet and make sure that I'm not telling people wrong, because I haven't looked at these for a long time. But yes, this is alveolar rhabdo. And again, it looks very different, right? I mean, right. It's a round blue cell tumor. It has really prominent fibrovascular septa in between, dividing out these nests of tumor cells. And this is kind of akin to how alveolar soft part sarcoma can have solid areas. You can also have solid areas in alveolar rhabdomyosarcoma, because the way they make the alveolar architecture is the same. The nests kind of break apart, right, and become discohesive. And so this can really confuse people, again, because they're expecting it to look alveolar. And you can see it beginning to get alveolar, like in here, right? It's beginning to kind of break down. But if you see a round blue cell tumor, alveolar rhabdo should be in your differential diagnosis in general. If a Desmond is a really important stain to do in the workup of a round blue cell tumor. And I think that can get overlooked sometimes. And here you can see them getting discohesive again. The fibrovascular kind of septa in between the nests is very helpful. The cells are round blue. Some of them will have some eosinophilic cytoplasm and can look kind of rhabdoid. We see a little bit of eosinophilic cytoplasm. Sometimes you see actual rhabdomyoblasts, like what they call strap cells, that are kind of like what you'd see in embryonal rhabdo. You can see those kind of scattered. Maybe like that guy there, they have a little bit more prominent eosinophilic cytoplasm. Striations you could sometimes see, but you got to really hunt around usually to find striations in rhabdomyosarcomas, I feel like. And then, like you said, those multinucleated wreath cells, let's see if we have any here. Those are quite helpful diagnostically, and they're usually present. But see, I mean, if you just had that, a high power pick of that, I mean, that could be anything, right? That could be a lot of different round blue cell tumors. I can't quite get it. It's a little bit too bright there. That's better. And that could be a wide range. You could think of Ewing's or Ewing-like sarcomas. You could think of a lot of different round blue cell tumors. Yeah, I don't know if I see the wreath-like ones. Well, I had a nice case that I pulled up the other day to use for a different video, and I guess I should have kept that one around. Well, in any case, they're multinucleated tumor cells with pink centers and nuclei around the outside. And if you Google it or look it up in a book, you should be able to find nice pictures. Dr. Weiss's book has good pictures. And I guess it sounds like you've already looked it up because you knew exactly what you're looking for. So these do tend to occur in children, sometimes young adults. I have seen rare examples in older adults, but it is extremely rare. But it can happen. So alveolar rhabdomyosarcoma. And among the rhabdomyosarcomas tends to be more aggressive than embryonal. And so what's the, did you see the, what was the question we had for this one? What's the molecular abnormality here?
So the translocation of 1 and 13 or 2 and 13?
Right, and that involves PAX3 or PAX7, and FOXO1 is the partner gene. Nowadays, I feel like, and I don't see these very often, I feel like they more often go to pediatric pathologists, but I feel like most of the time now people are pretty much always confirm them with molecular. I mean, this looks very characteristic and classic, but because the treatment protocols and the prognosis is different than embryonal rhabdo, I feel like usually people want to have the molecular to sort out for sure between embryonal and alveolar. Usually they look different, but I've seen times where it can be hard to tell them apart. So, all right, now what is the immunostain pattern you would expect in an alveolar rhabdomyosarcoma?
So desmin and MSA should be diffusely positive, and then myogenin and MyoD1 should have nuclear positivity, and it should be diffuse.
Yeah, that's the key there. Desmin, I don't know. I don't use MSA very often, so I'm not sure, but it wouldn't surprise me to have it positive. Desmin, definitely you want to have positivity, a lot of it usually. And myogenin should be like strong diffuse nuclear positivity, like 90% or more of the cells. Whereas in embryonal rhabdo and some of the other rhabdos, it can be more patchy staining. This one, this makes a great control. If you get alveolar rhabdo, it's good control tissue because it's just like all the nuclei, blazing positive for myogenin. And I tend to like myogenin better than MyoD1 just because in the labs I've been in, at least, it has is more clean stain, and MyoD1 can have a lot of background cytoplasmic staining, which is non-specific. So I feel like the labs where I've worked before, we've had trouble getting MyoD1 to work very well, although it is a good stain. It's just I feel like harder to interpret. So my experience has been mostly with myogenin, or also known as MYF4, MYF4 is the other name for myogenin. It's always good to learn the alternative names, for immunostains, because you never know, on a test, which name will get asked, and it's terrible to know something but not know the alternative name and be like, but I knew that fact. All right, so let's see. Next, we've got case 3, and this is a 45-year-old man with a slow-growing 4-centimeter soft tissue mass of the trunk. All right.
So it's well circumscribed.
Yep.
Encapsulated.
Guess I didn't clean that slide very well. There we go. Let's go and look closer at the cells.
So I felt like this had a couple different patterns. One of them being a storiform.
Okay.
Which.
Yeah, like right there. Storiform you can describe like 1,000 ways, but the only way to ever really get storiform is just to see it and then be like, that's storiform. This isn't like the most perfect swirly, spirally, pinwheel looking storiform, but there is kind of a vague swirling and whirling and merging of the cells. They kind of wrap and swirl around a little bit, right? Kind of a little bit haphazardly here and there, but you're right. There's kind of this whirling and swirling. Sorry, trying to get it. It was a little overexposed pattern. And I feel like that's what you see throughout much of it. Some areas you give some kind of short fascicles, but it's kind of a mixture between short fascicles and a little bit of swirling storiform. And I feel like you often get that kind of overlap in tumors that do swirl. Here's pretty nice kind of whirling and swirling pattern. Okay, so was your differential, and what kind of stains would you like to do?
So I was looking at doing like EMA.
Okay.
And like an S100.
Okay.
A Cloudin 1.
Good.
Glute 1.
So I can tell by your panel, you already know exactly what it is. This is going to be positive for, if you're lucky, for EMA, Claudin 1, and Glute 1, and negative for S100. So what would it be then?
Perineurioma.
Yeah, so this is perineurioma. Very beautiful example here. This is pretty nice for the swirling or whirling growth pattern. And yeah, to me, whirling and storiform do have a lot of similarities. They really can kind of overlap. I feel like whirling is more circular and storiform has like kind of spiky edges, but this is totally like voodoo basically. It's like, oh yeah, I see some whirling there, and the residents are always like, what, are you serious? So you do have to hallucinate whirling a lot. Sometimes you'll get really good whirling and swirling in perineuriomas, but other times they can be a little more subtle. So it is if you have a hard time as a trainee picking up, or even in practice picking up on whirling, you're not alone. I feel like I hallucinate whirling and think, oh, could it be? And I'll tell you, there's many times I go hunting for perineurioma and don't find it, much more often than I actually find it. So I'll be like, oh, could it be perineurioma? All the stains are negative. So I feel like I'm always looking for the perineuriomas, but only occasionally finding them. But this one stained nicely. And okay, what about other entities in the differential here? What other things could you think of? A variety of things you could consider. Or did you just look and say, it's perineurioma, done, like a boss?
That's kind of how I did it.
Nice, like a boss.
Like 2 weeks ago, but yeah. Otherwise, I would not have gotten that.
Well, I'll tell you this, a couple things that, again, Mark Edgar taught me this differential. He said, when you think of perineurioma, it's always good to keep dermatofibrosarcoma protuberans in mind, because the storiform pattern of that can look a lot like the whirling, swirling pattern of a perineurioma. The big difference there is most of the time when I've seen perineuriomas, they're circumscribed. And DFSP is going to be infiltrative and entrap adipocytes. So you'll have a lot of adipocytes trapped in the middle of a DFSP. He also said that low-grade fibromyxoid sarcoma is good to keep in mind because some of them have a whirling pattern, have a perineurioma-like pattern, which is very inconvenient that they can look a lot like this pattern. Now, they don't all. A lot of them don't have that pattern, but sometimes they do. And the thing about low-grade fibromyxoid sarcoma, perineurioma, and DFSP is they're all composed of bland, elongated spindle cells. Depending on the plane of section, sometimes when you cut them, they look more oval or round. And other times when you cut them, they're like thin and spindled. It just depends on how they're sectioned. You can kind of see here, they look a little bit more thin and elongated, like in this area. But then over here, they look more round or oval. And that's because perineurial cells are kind of like I think of them like if you hold your hand out like the palm of your hand, if you turn it one way, it looks thin and elongated. If you're looking straight on, like at your pinky or your fingers. And then if you flip it so you're looking at your palm, it looks like an oval. Hopefully those of you watching at home can understand what I'm doing, because I'm holding my hand up and looking like a fool, but I don't have my camera on. So in any case, I think, and that's because perineurial cells, their job is to wrap, right? They wrap and encase peripheral nerves. They're kind of like the peripheral nervous system equivalent of meningothelial cells. And so very rarely you can also have meningiomas occur in soft tissue. Oftentimes the head and neck, sometimes because they've grown through the skull, sometimes like in little kids, it's because of like we don't know for sure, but an embryonic rest of precursor cells that gives rise to a cutaneous perineurioma. Cutaneous meningioma. There's a few different patterns. They're quite rare, but I've seen a few of them before. And they can look very, very similar to perineurioma. So that's another thing in the differential. And what else was I saying? Oh, for low-grade fibromyxoid sarcoma, MUC4 would be a great stain for that, and it's going to be negative in the other stuff. DFSP, CD34 is positive. They can sometimes express some EMA, if I recall, and molecular can easily solve that. You can do FISH for PDGF. B collagen 1A1, or more recently described PDGFD fusions can be seen in a small subset of DFSPs. So those are good things to keep in your differential. And I feel like there was one other thing. Oh, it just occurred to me now. I didn't think of it before, but myofibromas can look a bit like this because they also whirl and swirl, but they tend to have whirling and swirling around the vessels. They will stain with actin, and they're going to be negative for perineurial markers. But I also thought they do have a kind of swirly pattern. So, and occasionally solitary fibrous tumors can have a bit of a look like this. I've occasionally seen people they're seeing cases that kind of overlap. So this is part of why soft tissue is hard, right? We're taking these kind of non-specific looking spindle cells with collagen and a tiny bit of bluish myxoidy background and describing a subtle nuanced pattern and then saying, here's a differential like 5 or 6 things. So this is why people find it hard, because it's challenging. Perineuromas are benign and beautiful. So a fun thing to get to see that's totally going to be okay for the patient. All right. So let's see, case 4, 55-year-old man with a posterior neck mass. Let's see, can I go? No, it's as low as I can go. Low power. All right, so what do you think about this one?
So we see that there is this intermixed fat, and then there's this collagenous component to this. I believe that there is ropey collagen in this.
Good, yes.
So I was...
All the buzzwords you're saying, good.
Yeah, so I was... And then you see some nuclei that are pleomorphic.
Yeah. And what kind of shape would you describe some of the pleomorphic cells have it? Maybe there's a good one over here. People have a
Triton.
Yeah, well, I never actually heard it described that way, but that works perfectly because Triton giant cells have ring-shaped, wreath-shaped nuclei, right? So people describe these as floret cells or wreath cells, that you get this kind of pleomorphic hyperchromatic nuclei, but they tend to be arranged in these kind of little irregular rings that look like petals on a flower, so kind of the floret or a little bit wreath-like. And I like that, Triton, like that actually is really good. Thank you. I'm going to start using that because, you know, everyone uses different, I always like to say this, that just because a visual clue or buzzword is in the literature doesn't mean that it works for you. And the point of visual buzzwords is that it's something that when you see it, you're like, oh, that looks like that thing, and then you get the diagnosis figured out. So if you don't like the buzzwords that the forefathers taught us, throw them out. I mean, you don't have to tell anyone, but or you can. Like I say that all the time. I don't like chicken wire. There's certain buzzwords I really hate. And so I find the ones that work for my mind. So yeah. So the multinucleated hyperchromatic atypical cells, the ropey collagen, we're seeing it everywhere. All these thick, fat bundles of dense pink collagen, okay? And then mature adipocytes, right? And so that a mixture of those three things is really helpful in arriving at the diagnosis of pleomorphic lipoma. And oftentimes, and pleomorphic lipomas, as I know you're aware, is on a spectrum with spindle cell lipoma. They are basically one and the same thing, just two different patterns of the same disease. They have usually have a loss of what's the molecular abnormality in these?
They have a deletion of RB1.
Yeah, exactly. RB1 loss or deletion. So that's on 13q, and sometimes they can have 16q deletion instead of 13q. So if you do immunostains, these tend to be negative for RB1, whereas nuclear RB1 staining should be seen in the background normal cells, but will be lost often in these, particularly these big atypical cells here. So it's not a totally sensitive. There are some that don't have loss of RB1, but it's a useful finding. And what was the other thing I was going to say? Oh yeah, the pattern can range a lot for pleomorphic and spindle cell lipomas. Sometimes there's a bunch of fat and only a little bit of the spindle cells and atypical hyperchromatic cells. Sometimes it's really abundant. Sometimes there's lots of myxoid change. Sometimes very little. It can really run a range, and the most common site is going to be the posterior neck or upper back, usually in men. I think the ratio is like it's 9-to-1 or 8-to-1, way more common in men, but it's so common in men compared to women that sometimes people get into the habit of thinking it just can't be this if it's in a woman, but that's not true. And Jennifer Coe and Steve Billings and colleagues at Cleveland Clinic wrote a really nice paper about spindle cell lipomas in women, and I think the same rule applies to pleomorphic lipoma, that spindle cell and pleomorphic lipoma can occur in women. And interestingly, they found that when arising in women, spindle cell lipomas tended to arise in unusual sites, like the extremities or the trunk, elsewhere on the trunk, or other places not the typical, like kind of shawl area, the neck, back, upper back area. So I thought that's really interesting, and it certainly fits with my experience that I've seen things that look like spindle cell lipoma and occasionally like pleomorphic lipoma, like in the extremities or other places that are not the classic location. So it's a really great paper. I'll try to put a link to that in the video description down below. And I saw it somewhere here, but a bubbly cell, it looked like a lipoblast. So that's the other thing, is lipoblasts don't always equal liposarcoma. You can have lipoblasts and multivaculated cells in a variety of different fatty lesions, and including spindle cell and pleomorphic lipomas. Occasionally, you can even see some mitoses, even rarely atypical mitotic figures, although there's some debate over what that means, and some people think that we should call lesions like that atypical pleomorphic lipomatous tumor, but that is an evolving area and kind of very muddy waters. I'm not going to go there. And I imagine that over time that may change a bit. So, okay, so what else would be in the differential for you here? What else? Did you worry about anything else? Or again, just like this pleomorphic lipoma, we're done.
Well, the liposarc did come around.
Sure. I feel like there are kind of two different ones that I consider. For one thing, I think a lot of people, because big pleomorphic cells, you think pleomorphic liposarcoma. The main thing for pleomorphic liposarcoma is that when you take the lipoblasts away from it, all that you're left with is basically UPS, undifferentiated pleomorphic sarcoma. There has to be like high-grade sarcoma there plus lipoblasts, okay? So here we might have a couple lipoblasts and we have some scattered atypical cells, but in between there's not enough cellularity for like a high-grade sarcoma, right? So that's, I think, the most helpful thing is that usually pleomorphic liposarc is going to be very cellular, either kind of spindled or epithelioid cells or both, and then lipoblast. And it usually you look at it and you're like, whoa, that's a sarcoma, like no doubt. So I think the thing that I find more tricky is telling apart well-differentiated liposarcoma, or atypical lipomatous tumor is the name for that when it's not in the deep sites like the retroperitoneum, when it's in the superficial soft tissues on the trunk or in the extremities, we call it ALT instead of well-diff liposarc, and they have scattered hyperchromatic pleomorphic cells, mature fat, and collagen. So a couple tricks that Dr. Weiss taught me is that number one, the collagen pattern in pleomorphic lipomas usually are going to be the thick, ropey bundles of collagen. And then the collagen pattern in a well-diff liposarc is often more like kind of hyalinized, homogenized collagen, real dense, homogeneous collagen. And that's one thing. So that's one thing that Dr. Weiss said was helpful, is the collagen pattern. And number two, usually if you look around a pleomorphic lipoma, you'll find some background small uniform spindle cells that look similar to the cells of spindle cell lipoma. Like you're kind of seeing that here. Admittedly, I think that maybe that's easier for her because she's like a master. I find that sometimes I can find that, but other times I find it difficult to be sure. But her point was that well-diff liposarcs don't usually have that small component of like uniform kind of spindle to oval cells that are similar to spindle cell lipoma. But pleomorphic lipomas usually do have that because, again, they exist on a spectrum with spindle cell lipoma. So you'll find these little uniform cells that kind of resemble the vaguely palisading or parallel arrays. See how the nuclei kind of stack next to each other? It's pretty subtle. But so, again, I think that's a very subtle clue, but that's one she pointed out. And, the other big thing is that usually pleomorphic and spindle cell lipoma are small tumors in the subcutis. Emphasis on the word usually. There are exceptions. I've seen big ones, and I've seen them rarely in like deep soft tissue sites like the muscle of the thigh. In that setting, I will only accept the diagnosis if I have some molecular evidence to support it, because it's very rare in that setting. And on the flip side, well-diff liposarc is very rare in the subcutis or skin. I mean, I've seen cases, but it's extremely rare. Usually is deep in a deep site, and usually large. So those kind of clues can help you, but if you're having a hard time, you can do MDM2 to rule out well-diff liposarc, and you can do RB1 if you want to help support spindle cell lipoma or pleomorphic lipoma. And these are totally benign. Despite how weird and atypical they look, even with margins positive, they rarely recur. So I find that pretty good to know about. Oh, that's a really nice example of a floret cell. Oh, and I think that's the other thing. You don't often see the multinucleated kind of ring-like floret shape in well-diff liposarcoma, but I have seen it sometimes. So if I see this even in a site where in fact, the confession time, the one time I saw cells that looked like this, but it was like a 10 or 12 centimeter mass in like the quadriceps, deep in the thigh. And I even thought, gosh, could this be like a deep pleomorphic lipoma? I talked about it with a sarcoma surgeon, and he was like, that doesn't make sense. This is growing like a liposarc. So I said, okay, and I didn't do molecular. I should have gone with my gut. They ended up resecting it, which is probably what I would have wanted anyway for that site. And then when it came out, guess what? It was pleomorphic lipoma. MDM2 negative. So I was glad that I thought of it, but also disappointed in myself that I didn't stick with my guns and pursue additional workup. And look, see that? Multivaculated. Looks like a lipoblast. Right. So you can see some lipoblast in these sometimes. But the wreath-like cells, if you see it, think about pleomorphic lipoma. So we beat that one to death, but these are really confusing for a lot of people, and people get really hung up and can make mistakes about them. So, all right. Next is case 5. Let's see here what the history says. And this is a 5-year-old female with a polypoid mass protruding from the cervix, the uterine cervix. All right, so what did you think for this lesion?
So it's obviously polypoid, as you had said. It's got a stratified squamous epithelium on top of it. And then underneath you have this loose appearing stromal component to this.
Yes.
And I was debating whether there was or was not a Grenz zone in this.
Grenz zone?
Yeah.
Okay. You mean like a layer where it's not involved? Or
yeah.
Okay.
Yeah.
Well, I find, I only really think of Grenz in the setting of derm path, not so much mucosal sites. But regardless, I also find, even though a lot of people talk about Grenz zone and teach it, I personally find that it, for most of the time, is not that helpful of a concept in derm path. It's very popular. Everyone loves to talk about Grenz zone, and so I'm probably one of the outliers there that I'm always like, things that are supposed to have Grenz zone sometimes don't. The one time I find in the skin is granuloma faciale, almost always has a nice, well-developed Grenz zone. So I find that's one time that it's really obvious, but I feel like it's a concept that's taught a lot, but in practicality, for me at least, I don't find it too useful. But your thinking of it is totally reasonable because people always talk about it, but it just is one of those things that never really clicked for me, even though people say it's a useful feature. So maybe I'm just not good enough to figure it out. So yeah, this loose kind of myxoidy stuff with spindle cells. Okay. And then here we get a little bit more cellular areas, kind of up here right under the surface. Okay, so did you have an idea for what this might be?
I came up with a differential.
Okay.
Two things. So, like a fibroepithelial stromal polyp versus the embryonal rhabdomyosarcoma, the Pathology type.
Very good. I think that's a very reasonable differential because fibroepithelial stromal polyps that can be seen in genital sites, they can get very cellular and weird looking, and it's always good to think about those. I don't know if they can occur in the cervix, so I'm not a gynecologic pathologist. I'm guessing that probably they can, but I guess the times I mainly have seen them is in the vulva, but that's purely probably because I'm a derm path, and so that's the ones that end up coming to me. But they can look weird, and it's always good to think about that benign option for weird-looking spindly tumors in the genital region. But in this young kid with the polypoid mass in either in the vagina or the bladder and one of those hollow viscous organs, that's like the classic buzzword for botryoid type embryonal rhabdomyosarcoma. And these usually are loose and very hypocellular. I mean, look, you would never look at that if someone gave you a high-power picture and said, oh, rhabdomyosarcoma. No one would think that, right? It doesn't look anything like it. So this is one of those where that classic history and the low-power pattern really, really help us. These are classically supposed to have a layer of increased cellularity right underneath the epithelium, which is called the cambium layer. I think it's like the cambium layer in like trees or something with like, I think there's like those different layers, the xylem, the phloem and stuff inside of plant stems, but I can't remember that at all. I like to garden, but I know nothing about botany, like nothing. So in any case, someone out there, if you're listening to this and you know more about cambia than me, you can educate me, please. But I've only seen a handful of these, and I would say that the cambium layer is one of these things that's a real cool concept, but in real life, I don't feel as well developed and beautiful as it's shown in books sometimes. But the idea is that you do get condensation of the stromal cells, and it tends to be kind of close to the epithelium. So, I kind of feel like here we're getting a bit of a cambium layer. I don't know. I think it's kind of a stretch. So, and this case was, of course, maybe we had a better area on one of the other pieces. Let me look. Oh, yeah, there. I think you can see a little bit here. See how the spindle cells are kind of clustering a little closer together, but you got to really hallucinate. Let's face it, okay? And, someone really smart, Alex Lazar, he's a dermatopathologist and soft tissue pathologist at MD Anderson. He said something, we were giving a course together, and he said, when you have to go and like look for an hour to find in your study set to find one slide that shows the classic characteristic finding, maybe that means that classic characteristic finding is not really that helpful. Like maybe it's a specific finding, but it's very low sensitivity if you have to really hunt around forever to find one example in your study set to take a picture of for a book. But of course, we like to take pictures like that when we write books or we make videos or whatever for teaching. We want to show the classic example, but it's also good, I think, for us to see the range of non-classic things, because that's what we see in real life, right? Is we see the stuff that breaks the rules and doesn't follow. And sometimes by seeing only the prettiest of pictures in books, we can get a little deceived into what things can really run the range of in real life. So this was Desmond positive, myogene positive. And my understanding is that these have a really good prognosis overall. I don't know much about the treatment, but they have specific protocols. Most of the pediatric rhabdomyosarcomas, they have specialized protocols and are handled by pediatric oncology people. So I don't really know about all of that, but I do know that what I've read is that this is usually a good behavior. So very nice example, I think, and good thing to keep in mind. Okay, let's see what's next. So next is case 6, and you have not seen this slide yet because I just pulled it. It's a 25-year-old female with a dermal nodule on the shoulder. And you can see someone biopsied it in the past, and there's the biopsy site, and then they went back and excised it. And it's got a very unique pattern from low power, doesn't it?
Yeah.
And this slide is actually courtesy, although she doesn't know I'm using it, but hopefully she'll forgive it, of my very first dermpath fellow, Hillary Elwood. She sent me this very, very nice example in a recut exchange. So I think the appearance to me is very nested, right? We have these or micronodular, whatever name you like. We've got cells. You can't really see much about their shape yet. They're clumped together in these like aggregates that have very thick fibrous septations dividing them from one another. And then even within these islands, you can see there's like little swirled tiny micronodules in there, right? So that's kind of interesting. And it's very circumscribed around the outside. And I didn't really show it at the top, but there's no involvement of the epidermis. It's totally a dermal and subcutaneous nodule. When we get closer, the cells are kind of like oval to round nuclei. Let's see if we can get it to focus there. Yeah, kind of oval to round nuclei. Relatively uniform, at least in this area. A very pale, kind of fine, delicate chromatin, a little bit washed out in white. I find that actually a pretty useful feature for this entity. It's certainly not a specific finding. Other things can have it, but when I see these kind of oval to round nuclei that have this real pale chromatin, it makes me think of this. And they almost look like kind of like histiocytes a little bit, or because they're kind of aggregated into almost these nests, you could think of melanocytes too, right? Or at least I do. And sometimes they can look very much like spitzoid melanocytes. But the key here is if you do immunostains, this is going to be negative for SOX10, negative for S100, negative for MART1, Melon A, whatever, negative for melanocyte markers. Okay? So, do you have any idea what this might be? This is one of these things that's not very common, and if you've never seen them before, you'll probably be like, no way. I mean, they're pretty uncommon.
So our dermpath fellow 2 years ago obsessed over this, and so I think this is a cellular neurothekeoma.
Nice! Well, your dermpath fellow did well. Their obsession taught you. Good. This is a really nice example of cellular neurothekeoma. They can run a wide range, so it's a good thing to keep in mind anytime you see something that looks kind of nested and melanocytic but doesn't have an epidermal component. Like if you think of a dermal spitz, always keep cellular neurothekeoma in the back of your mind. They can sometimes have really prominent nuclear atypia. They can have mitoses, even atypical mitoses, and yet have indolent, benign behavior. So it's something that if it were melanocytic, sometimes the features would make you say, well, this has to be melanoma. But once you're into neurothekeoma land, it's fine. They look kind of melanocytoid, histiocytoid. They are nested. That's the key, is recognizing these little tiny micronodules or nests, often with fibrous septa in between. That's really helpful. I find that kind of pale, washed out nuclear chromatin to be helpful. This one doesn't have it, but many of them have myxoid change, and sometimes it's very prominent, abundant myxoid change in some cases. And they often have multinucleated giant cells. I've been looking around, but I'm not finding really good examples in here, but you can see multinucleation. So I find the most helpful thing is once I have this pattern on the H&E, and then I've done a SOX10 or an S100 to exclude melanocytic differentiation, then I feel pretty comfortable with saying, oh, it's cellular neurothekeoma by exclusion. But if you want to try to prove it, there are some stains that are positive, but the problem is that none of them are terribly specific. The stains are supposedly S100A6, not regular S100, but A6. It's like the A6 subunit. I don't understand molecularly what exactly it is or why it's different, but it's supposed to stain these. I've never had a lab that had that in it that I worked with previously, so I never really used it much, other than cases that sometimes would come in occasionally with it sent with it. Also PGP 9.5, some sort of a growth protein, I think. I don't know what it does actually. PGP 9.5, and why am I blanking on the last NKI-C3? That's what it is. NKI-C3. So those are the three buzzwords. So for boards or testing purposes, if you hear those buzzwords, those are usually in the setting of soft tissue or skin. You're talking about cellular neurothekeoma. They're not specific markers, though. They can stain various melanocytic and or histiocytic entities. Even though this is called neurothekeoma, it is actually not a neural tumor because it's negative for SOX and S100, right? It's the best current thinking, to my knowledge, the last time I did a deeper dive into this, is that they're probably some sort of histiocytic sort of, or fibrohistiocytic precursor. So the name, and I have a whole video about this and you can watch if you want, and I'll put a link down below. The name neurothekeoma is because there is a nerve sheath tumor called nerve sheath myxoma, and it has swirly myxoid areas, and it's a real nerve sheath tumor. It used to be called conventional neurothekeoma or myxoid neurothekeoma, and then this tumor can sometimes have areas that looks just like that. And so a long time ago, people thought, oh, they must be all related. And then with immunostains, we found they're actually not. They're unrelated totally, but they can look alike. So again, that video will go and explain if you really want to go take a trip down memory lane into history and find out how all this confusion happened. But this is a really nice example of one. Cellular neurothekeoma. Wow. All right. Now, case number 7. Man, I didn't even let you preview that one, and you nailed it. I'm pretty impressed. That was very good. Okay, let's see. So case 7. And no, I didn't edit that in there. This is real time live. Terrance got that one without any prompting. Okay. So case 7 is a 35-year-old female with a 4-centimeter mass of the proximal leg. Let me clean that one off a little more. Oh, wow.
So it's well circumscribed, nodular. You have these dividing septi between these nodules themselves. There is a mature adipose component.
Yep. Definitely got some mature fat in there. What else?
And then you almost get this, there's like this different type of cell almost.
Yes. Hard exactly to say what kind of cell it is, right?
But if you kind of hallucinate at this point, like at this very field, it kind of looks like almost trying to be like a piece of cartilage almost.
Yeah. Nice.
How I would describe it.
But I like that you pointed out you have to hallucinate, because I totally agree with you that even though the name, and I believe it was actually named by, I guess, one of my academic ancestors, Franz Enzinger, who trained Sharon Weiss, who trained me. So even though he made the name and he named a lot of very important soft tissue tumors, yeah, I kind of feel like the small handful of these I've seen are supposed to look chondroid, but they don't look super cartilaginous to me. They don't really look like a real cartilage. But I guess they got that kind of bluish, kind of chondromyxoid background, and the cells kind of individually sit in their individual spaces, like lacunae. I guess I can kind of see that. And then, so obviously you know what this is going to be. And then the last thing that we see is, in addition to these cells kind of sitting in the chondromyxoid background, what about these guys? I mean, what would you call a cell like that with lipid bubbles that are totally clear, indenting the nucleus?
I was calling that, because I thought those were lipoblasts.
I mean, they got to be lipoblasts, right? I mean, whatever name anyone wants to call them, to me, that's a lipoblast. It is a true lipid vacuoles in a mesenchymal cell, right? The only thing that really looks like that, outside from lipoblast, is like a sebaceous cell, sebocytes, right? But these are not epithelial cells, so it can't be that. So to me, and the reason I bring this up, and if I recall, it was probably this very case, actually, when I was in fellowship. And some of them kind of have a slightly granular, reddish sort of looking cytoplasm too, kind of eosinophilic cytoplasm, and others are more bubbly. And then these are the cells that kind of make the little single cells and a little bit of cords and chains and that kind of in the chondroid areas. So what's the diagnosis then? And then I'll tell you my story.
Chondroid lipoma.
Chondroid lipoma, exactly. And I mentioned to you earlier before we started this video that there are sometimes that actual lipomas can get cartilage metaplasia, and that's different. This is a specific entity that is not a lipoma and not a cartilage tumor. It's its own kind of entity. And they have lipoblasts. So when I saw this case, actually in fellowship, I remember I looked at it and I was like, what the heck is this? And evidently I didn't do enough reading to figure out what it was like you did. And so I said, well, Dr. Weiss, I don't know what this is, but I think it must be some sort of liposarcoma. I mean, it's got lipoblast. It has to be a liposarc, right? And she was like, something like, well, Jared, you missed the chance to make a really rare and interesting diagnosis. And I was like, oh, and the shame of it still lives with me to this day. So sometimes our misses in training, things we get wrong in training, that's a great time to get stuff wrong because it really like teaches you for the long run. So this is in fact a benign tumor, chondroid lipoma, and a really nice example of one. And sometimes they can get really unusual vascular changes, like with a lot of hemorrhage and fibrin deposition around vessels. And I just showed one recently to the residents at McGill University in Canada, and I didn't know that could happen actually, because again, these are rare. I've only seen a handful of them. And they said, oh yeah, and so I must have skipped that day of fellowship too. And they told me, oh yeah, you can totally have that. And I went and looked it up, and yes, they were right. So I learn a lot from getting stuff wrong clearly. So chondroid lipoma, really fascinating entity and extremely rare. All right, now let's see. Case number 8 is a 40-year-old female with a liver lesion. All right. Well, that doesn't look like normal liver, does it?
No.
I mean, I'm not a gastrointestinal pathologist, but I'm pretty sure liver is not supposed to look like that. There is a little bit, I guess there's a capsule out here of the liver, I believe. And then here's some background hepatocytes. And then that goes away, and we got something else.
And it looks like it's just like this. It's almost hard to even like say it's like a spindle cell thing. You just see like the nuclei because the fibers aren't like separating very well. They're just very tightly packed. And then you see some, I believe, fat interspersed.
Yeah, there is some fat in there. Let me see if I can get the white there. That's better. The white balance is a little bit too bright, so that's better. So yeah, what kind of, if you had to describe the kind of the color or hue of the background, ignoring the cells and the vessels and the fat and stuff, but this bluish pink kind of background, are there any words? What visual word would come to your mind? There's an answer of what it's supposed to look like, but again, what it looks like to you is more useful and meaningful to you, actually. I mean, I don't know. Like, see how blue that looks there?
Right. It's like a periwinkle blue something.
Well, I like that periwinkle blue. I'm learning a bunch of new stuff. I'm gonna have to when I get videos in the future, I'll be like, as my former resident Terrance Lynn used to say, periwinkle blue color is very characteristic. It's great. All right, man.
Yeah. Other than that,
some people describe this as chondromyxoid.
Yeah.
Because it's kind of bluish and smudgy. And, I feel like chondroid and myxoid really can overlap sometimes. I don't know how to describe it, but it looks dense, right? Like myxoid looks like real loose, gooey stuff that you could think would just fall apart. And chondroid is very dense looking. And I don't know how to, if you're beginning at pathology and you're like, what are you guys talking about? How could it be dense or loose? I don't know how to explain it, but there are certain times where the density of a color under the microscope looks like if you touched it, it would be hard versus soft. And maybe that means that we've been doing pathology too long, that we're drinking our own Kool-Aid and believing the voodoo. But in any case, yeah, this kind of dense, homogeneous looking, pinkish blue background that is effacing and wiping out the liver. And when you see that is this entity till you prove it's something else, at least in my book. Okay, so what did you think the diagnosis was? Did you figure it out? This is challenging here, especially I think in this context it can be challenging.
Well, I'm going to say I had to page through my textbook.
Nothing wrong with that, man.
But I think this is an epithelioid hemangioendothelioma.
That's exactly what it is. Very good. Epithelioid hemangioendothelioma, and they are vascular neoplasms of intermediate malignant potential is what all of the different hemangioendotheliomas. And by the way, there are multiple different hemangioendotheliomas, and they are not related. They are all just called hemangioendothelioma because they're vascular tumors that are not fully aggressively malignant like angiosarcoma, but not benign like hemangioma. So hemangioendothelioma indicates this kind of intermediate malignant potential. But it's a little problematic because sometimes people think, oh, they're just different morphologic variants of one thing. The epithelioid hemangioendothelioma is its own unique entity. Kaposiform hemangioendothelioma is its own unique entity. Pseudomyogenic hemangioendothelioma, totally separate. They look separate, have different molecular, different behavior, everything. So that's one thing to remember. And never call something hemangioendothelioma NOS. Never do that. What that means is vascular lesion, and I don't know what it is. That's just wastebasket category is what. That's a case that needs sent for a consult. So these tumors were, I think originally described in the lung, and people thought they were carcinomas for a long time. Because the thing about them is, and this case doesn't really showcase it as well as it should, because there are a lot of vessels here, but those vessels, I believe, are background vessels in this case, background vessels from the liver. Epithelioid hemangioendothelioma usually do not make vascular channels. So for a long time, people did not realize that they were vascular tumors, and it was actually Sharon Weiss who figured out in the early 1980s that these were vascular tumors, and she proved that with immunostains and electron microscopy, which was a really very forward advanced thing that no one had figured out before. They can be in the lungs and the liver, but also occasionally in skin and soft tissue. And they tend to present as multiple lesions. So I kind of was tricky here. I just said a liver lesion, but oftentimes these patients show up with multiple lesions in the liver. The idea is they kind of metastasize locally or sometimes distantly before they're even discovered, but then they kind of just sit there. Oftentimes they're very slow growing, and then sometimes they can advance later. But they certainly are not as rapidly aggressive as angiosarcoma often is. But they are not benign, and among the different hemangioendotheliomas, this one seems to be more problematic than the others. It can metastasize, it can kill people. I'm in a patient group for epithelioid hemangioendothelioma patients on Facebook. And it really causes significant problem to those patients. So usually it makes nests and cords and chains of epithelioid cells. I probably should have put in a different example because it's really hard to tell here because you've got some background hepatocytes mingled in here that are not part of the tumor. You've got some background vessels. And I never thought of it before for this case, but there is a subtype of this tumor that does occasionally make vascular channels. And I'm wondering if this is one of those. I think this case was from a long time ago before we had the molecular we knew the molecular features, but I'm trying to find a good area to show you the definitive cells. I saw it earlier. Let me look under the scope again and see if I can find it. But you tend to get these epithelioid cells in little cords and chains. But again, it's really complicated, I think, in the liver and the lung because you have background normal epithelial structures. And they often do this. It's filling the vessel, see? See, it's like growing through, plugging this vessel, growing through the wall and expanding out. That's how it often grows. It rises from a vessel and expands outward and can have like plugs of tumor cells filling the vessel. So here we can see that the nucleus is kind of out of the plane, but there's a vacuole in the middle and there's a little blob of stuff in the middle. So you get like fragments of broken down red cell in these little tiny spaces in the middle of the epithelioid cells and their cytoplasm. Here's another one right here. And what this is that this is the tumor cell, and they're trying to make lumens, and they can't quite make real lumens, so they make these little intravascular primitive lumens, and little red cells get in there and get stuck in there and degenerated. And so that's called the blister cell, right? And that's the classic cell of epithelioid hemangioendothelioma. And in these cases, again, because the liver and all the stuff is intermingled together, it helps to actually see it on a vascular immunostain to give you a better sense of the pattern. I should have probably used a soft tissue example because they're a lot easier to see the cords and the chains of the tumor cells. And they can sometimes express keratin, which can be problematic because they look epithelioid and they can be keratin positive. So it's really easy to mistake them and call them carcinomas or things like that. And I do have another video I made recently with a different example of this entity in the skin, I believe. And I'll try to remember to put the link to that down below, so that you can go and check that out and see another example where it's more easy to tell. And so here's more of those blister cells. So liver and lungs are good sites. When you see that chondromyxoid stroma, always think of it. When you see little clusters and cords and chains of epithelioid cells, that's epithelioid hemangioendothelioma. And these, did we ask the molecular on this? Do you know what the molecular relationship is or diagnosis is?
I think it's a translocation 1 and 3.
I can't remember actually the chromosomes, but I think you're right.
But it's WWTR1 and CAMTA1.
Yeah, WWTR1 CAMTA1, which that came out like right around the time I was graduating fellowship, actually. So that is a fusion that's in the majority, and then there's a small subset that have YAP1, YAP1, TFE3, and so that one will be positive for nuclear TFE3, and also that form can actually make some vascular channels. I don't believe that I've ever seen a definitive example of that type before. But usually I teach, if you see vascular channels made by tumor cells, then you're probably not dealing with epithelial hemangioendothelioma. But there's always going to be exceptions to the rule. So I think that's a good thing to keep in mind. Oh, that's the blister. So look at that one. Nice. And I would point out that a lot of different vascular tumors can have vacuoles. Okay, pretty much most vascular lesions that have epithelioid-looking endothelial cells, both benign and malignant, can make cytoplasmic vacuoles. Epithelial angiosarcs can do it, epithelial hemangiomas, spindle cell hemangiomas, and probably others. But the little red cell fragments floating in the vacuole, the blister cell, I don't feel like I've seen good examples of that. The main thing that has that is epithelial hemangioendothelioma, EHE. So important entity to know about and to be able to diagnose, and don't want to confuse it with angiosarcoma or benign things. And again, really problematic, particularly when it occurs in the liver or the lungs. It's quite problematic. And I think the fat in there, I imagine, is background like fat or lipid from the hepatocytes, but I don't know for sure. All right. Let's see. Number 9 is supposed to be a finger lesion in a 34-year-old female. And you'll probably know, because the other slide you looked at earlier, which I replaced it with, this is just a much better example than the one that I showed earlier. So, do you know what this is?
I'm going to say I think this is a myxoma, but I thought the location was weird.
Okay, that's fair. It's very myxoid, right? So the one thing that I guess would be weird for myxoma is this is a very sharply circumscribed into lobules, right, with fibrous septa in between. Now, cutaneous myxomas or superficial angiomyxoma do actually usually have lobules, but not, at least none that I've seen so many. Like these are multiple little nodules that are very tightly wrapped in collagen. So when you see something that looks myxoid and has this pattern, that's very characteristic for this entity. And acral surfaces are pretty good site for this entity. The other thing is, and this one is great. This is the first time I remember when I first saw this case, and I thought, whoa, what's going on here? It looks almost like nuclear palisading, doesn't it? If you've got a good imagination, see those line up, and there's a space there that's kind of like almost like a Veracay body. So I thought, well, that's kind of cool. I didn't know that you can have that in this entity, and indeed you actually can sometimes. But if you stain this is S100 positive and SOX10 positive. This is a nerve sheath myxoma, which used to be called in the olden days conventional neurothekeoma or myxoid neurothekeoma. So this is the cellular neurothekeoma sometimes has areas that look a lot like this, a lot swirly and myxoid, and so people thought they were related. But these are always positive S100 and SOX10. They are true neural lesions, and they look like myxoma. So like you said, they are like myxomas, but they are actually a true neural tumor. And why I like this case is really cool, because when I first saw this case in practice, it was pretty early in my practice, I saw those palisades, and I thought, oh, I wonder if maybe there's like a myxoid multinodular variant of schwannoma. And when I looked that up, actually, one of the papers about nerve sheath myxoma came up. I think it was Dr. Mietinen and Fetch and Laskin. They wrote a real nice paper about this. And they said in there that things that in the past were called myxoid, variants of or multinodular myxoid schwannomas are actually probably nerve sheath myxoma. So I was like, oh, so that it proves the concept that they really are nerve sheath tumors. They kind of have a schwannoma-like appearance occasionally, but I would say that's only a minority of cases that I've seen that have like the palisading. Usually, what they have is more like this. This is really characteristic. You get spindle cells, and they kind of, I feel like they kind of swirl around in this loose myxoid background, and they're like kind of spindle cells that are following each other, like in kind of a irregular rows that are spinning around. They're like kind of running around in circles in a big field of myxoid or something, and it's kind of this vague whirling, kind of swirling dance of spindly cells in a myxoid background. So this is a nerve sheath myxoma. And they are benign and, again, unrelated to cellular neurothekeoma, even though occasionally cellular neurothekeoma can look like this. If you get cellular nodular areas and areas like this, then you're dealing with a cellular neurothekeoma. These areas, this tumor does not get cellular nodules, but cellular neurothekeoma does get loose myxoid areas. So, and again, I got that video that explains, because this has been a source of endless confusion for people for years, because the old literature has kind of confusing overlapping of the names. So anyway, that's a really nice, that's a good palisade. Look at that. See, it looks really like a varicose body, huh? Isn't that wild? Really cool. And these are benign. They can recur sometimes, but they're benign. All right. Nerve sheath myxoma. And then let's see 10. I've got a big circle here, so I guess that means something's good in the middle there. And let's see. This is a 35-year-old female with a history of neurofibromatosis 1 and a rapidly growing soft tissue mass in the deep soft tissue of the trunk. If only we got specific histories like that every time, right? Yeah, there are big pink, and I feel like epithelioid and rhabdoid can really overlap sometimes, right? Because they're both cells that have abundant cytoplasm that's eosinophilic. So, and then if you take the kind of epithelioid or rhabdoid cells out of the equation, the background cells that we're looking at really are pretty spindly and kind of run in fascicles, right? Like this. And I can't remember where, but I mean, there's mitoses around, atypia, nuclear atypia. So it's a malignant looking spindle cell tumor that's arranged in fascicles. So if you just had malignant spindle cells in kind of, they're almost a little bit herringbone, huh? Can you kind of vaguely elucidate that? Herringbone is, means that like the fascicles, instead of being at 90-degree angles, like say in a leiomyosarcoma or leiomyoma, they kind of come into each other at very sharp angles. And so they give you the kind of fish backbone look or chevron look. This one is certainly not the best example of herringbone pattern. I actually have that on my list of things to make as a video about herringbone pattern. But when we see malignant herringbone-looking thing, spindle cell tumor in the setting of NF1, the main thing we want to think of is malignant peripheral nerve sheath tumor, which is a neural sarcoma that people with NF1 unfortunately have a significant chance of developing, and also it can occur sporadically outside of the setting of NF1. So, and this example here, and I didn't give you any immunohistochemical findings, so it makes it harder, but this one here has these big rhabdoid cells, and those actually would stain with desmin and myogenin. So they're actual rhabdomyoblasts. Tons of them in this case. Usually it's much more focal. So when you have a malignant peripheral nerve sheath tumor that has heterologous muscle differentiation, and you can almost see, you can't really see striations, but you can see, I don't remember, maybe the circles because some of these had striations, I can't remember. But if I flip the condenser here, you can see how the cytoplasm of these is like stringy, right? It's because it's made of myogenic fibers. And so it's like these little swirly, stringy, swirly looking cytoplasm. And that's characteristic of rhabdomyoblasts. They often do that. And sometimes you will see actual cross striations. I guess I should have looked before we did this so that I could find the cross striations, although it's very hard often to get them to show up in pictures because it's one of those things you have to kind of see the three-dimensionality to get it. And this one also even has a little bit of almost like kind of cartilaginous look there. See, like kind of strange. So anytime a sarcoma makes a tissue type or a tumor cell type that's not not normal for that native tissue, we can say that that's heterologous differentiation. It's just kind of a fancy old-time word for tumors that are making different tissue types than they're supposed to. And we can see carcinomas do that too, right? When they get poorly differentiated, like in the the uterus, sometimes like what used to be called malignant mixed Mullerian tumor. I don't know. I don't think it's still called that, but high grade carcinosarcomas or sarcomatoid carcinomas that develop osteosarcoma or chondrosarcoma or rhabdocomponent, that's called heterologous differentiation. So when MPNST does that, it's called malignant Triton tumor. Triton, like the god of the sea, but actually that's not what it's named after. It's actually named after the Triton salamander. And my understanding from my brief reading on this is that when you cut the tail off, I don't know why someone does that to the poor salamander, but if you cut the tail off the salamander, as it grows back, there's both neural component and skeletal muscle component mingled together that kind of reminded someone in history and pathology, I guess, of this tumor. And that was the kind of thought, is that it resembled what Triton salamander tails are doing when they regrow. Okay, that's cool. We all now know that tumors come from stem cells, right? Tumor stem cells, and that sometimes those cells have the potential to give rise to various other tissue types that are not the normal tissue, right? It's not, malignant peripheral nerve sheath tumor doesn't grow from like normal benign nerve, just like squamous cell carcinoma doesn't grow from normal benign epidermis. There's some stem cell, right, that mutates. That's the kind of theory we have. Well, I've looked around this area for a while here, and I'm not finding the striations. As soon as we stop recording, I'm sure I'll find it. But I think the moral of that story is that cross striations in rhabdomyoblasts are very hard to find. The time you're more likely to find it is in the setting of heterologous rhabdomyosarcomas. Differentiation. True rhabdomyosarcomas, primary rhabdomyosarcomas, I feel like you really have to get lucky to find cross striations. I feel like the best ones that I've ever seen were in the setting of malignant Triton tumor, or other settings where there was heterologous rhabdomyosarcoma differentiation in some other type of tumor. And my understanding is that it's because the skeletal muscle that gets produced here is a little bit more mature, whereas in true rhabdomyosarcomas, it's a little more immature. But the kind of stringy pink cytoplasm here is very characteristic of rhabdomyoblasts. I think that's helpful. And let's see, I've got a whole long video about MPNST. It's kind of a complicated topic, but the basic take-home point is that the ideal thing you want to see is a sarcoma that's growing out of a nerve, out of a neurofibroma, or in a patient that has known NF1. Outside of that setting, you should be really hesitant to definitively call something MPNST, although it does happen. We do now have a nice stain for it. It's called H3K27ME3. I had to practice it a bunch of times to say it from memory. And it's a nuclear marker that is lost in malignant peripheral nerve sheath tumors, particularly ones that occur sporadically outside of the NF1 setting. So it's very helpful in that context. It can be lost in other things, like melanomas can lose it, D-diff liposarc occasionally. So it's not a totally specific marker, but it can be very helpful. What was the other thing I was going to say? Oh yeah, and paradoxically, malignant peripheral nerve sheath tumors do not usually express S100 or SOX10. If they do, about half of them will be negative, and the other half is going to usually be weak, patchy staining, not strong diffuse. There are rare exceptions, but usually MPNSTs are either negative or weak, patchy. Strong diffuse S100 should make you think much more of like metastatic melanoma or something like that, with the exception being epithelioid MPNSTs, which do have strong S100, and they do look like metastatic melanoma. And that's usually the main differential there. So anyway, that's why I made a long video about MPNST, because it's a very complicated topic with lots of misconceptions. And these are very aggressive tumors, unfortunately, all MPNSTs. The Triton tumor aspect of it doesn't change its behavior to my knowledge. But it does sometimes cause confusion because it can look very different than traditional MPNST. So really, this is like one of the more dramatic examples of Triton tumor that I've seen, because there's so many rhabdomyoblasts in here. So, all right, so that is malignant Triton tumor, MPNST. All right, I think that's all 10. Well done. Thanks so much.
No, thank you.